a 33-year-old woman with abdominal pain, vomiting, and erythema. Case report. A 33-year-old woman was admitted to our hospital because of upper abdominal pain, vomiting, polyarthralgia, and erythema. The patient had been in generally good health, but when she was 27, morning stiffness and on motion pain over the right elbow developed and gradually progressed to bilateral involvement of the hand, knee, foot, and the proximal interphalangeal PIP and distal interphalangeal DIP joints. At 29, she was found to have Raynaud's phenomenon and sclerodactylia, but both disorders resolved spontaneously in 2 years. At 30, she had an appendectomy, and high fever lasted for 8 days after the operation. In January 2005, a month before admission, she had high fever, swelling of the right cervical lymph nodes, and localized edema on the forehead, eyelids, and legs. These symptoms resolved in 3 days without therapy. In February 2005, she was admitted to our hospital. Present admission. She is not married, and her parents and 5 siblings are in excellent health. Physical examination revealed erythema multiforme, discoid rash, on the chest, palms, and back, conjunctival injection, angioneurotic edema on the forehead, chin, and flexor surfaces of the forearms, and polyarthritis involving both hands, both elbows, and the right foot. Uncorrected visual acuity is 20/40 in the right eye and 20/30 in the left eye. Corrected visual acuity is 20/20 in the right eye and 20/30 in the left eye. Results of other physical examinations were normal, except for slight pressure pain on the abdomen. Results of blood chemical laboratory studies, as well as the upper gastrointestinal röntgenograms, were normal. In addition, the feces tested negative for occult blood, and the urine contained no protein and few casts. Hematologic and immunologic laboratory tests showed that no lupus erythematosus cells were present, but the serum tested positive for anti-nuclear antibody, ANA, at a dilution of 1 to 1024. Cellular immunity, such as T cells, B cells, and stimulation index with phytohemagglutinin, were within normal range. In serum analyses for complement, serum C3 was 20 milligrams per deciliter. CH50 was 11 units per milliliter. Normal range is 33 to 61 units per milliliter. And the serum tested positive for C1q precipitants of the low molecular weight type. In March 2005, 1 month after admission, swelling appeared in the right cervical and right axillary lymph nodes, and the biopsy specimen showed chronic lymphadenitis. A renal biopsy specimen disclosed slight proliferation of mesangial cells and subepithelial deposits. Diagnosis and therapeutic intervention. Our diagnosis was a systemic lupus erythematosus SLE-related syndrome, with special reference to hypocomplementemia and the presence of circulating C1q precipitants. This is classified as incomplete or latent SLE. Prednisolone therapy was initiated at 15 milligrams per day and was subsequently increased to 30 milligrams per day. Erythema multiforme was alleviated quickly, but fever, polyarthritis, and angioneurotic edema persisted and were ameliorated only after prednisolone was increased to 60 milligrams per day. We prescribed famotidine, 10 milligrams, 2 tablets, PO, twice a day, to prevent gastric ulcer. The patient's serum C3 rose to 50 milligrams per deciliter after prednisolone was increased to 60 milligrams per day. Discussion. SLE, one of the Cologan diseases, often develops between the 3rd and 5th decades of life. Because this patient exhibited only 3 of the 11 diagnostic criteria for SLE, a diagnosis of SLE was precluded. Instead, we made the diagnosis of SLE-related syndrome and subnamed it the Agnello-Oishi syndrome. This syndrome is characterized by erythema multiforme, angioneurotic edema, marked hypocomplementemia, and C1q precipitants of the low molecular weight type. After the patient's intake of high-dose prednisolone, the C3 increased by 150% in spite of the immunosuppressive activity of this medication. This phenomenon gives rise to the view that an immune mechanism itself is involved in the marked hypocomplementemia associated with this particular SLE-related syndrome. Since C1q precipitants of the low molecular weight type are known to consume complement, we propose that C1q precipitants are not a result of this syndrome, but a cause. Complement deficiency appears to predispose the patients to an SLE-like syndrome and may pose a high risk of progression to full-blown SLE.